I am Dan Tizik. Today we will be conducting a data subcommittee meeting of the Commission to Study Environmentally Triggered Chronic Illness. Before we get started, I'll read through a checklist to ensure that the meeting that we are holding is in compliance with the Right to Know law. As a member of the Commission to Study Environmentally Triggered Chronic Illness Data Subcommittee, I find that due to the state of emergency declared by the Governor as a result of the COVID-19 pandemic and in accordance with the Governor's Emergency Order number 12, pursuant to Executive Order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the Governor's emergency order. In accordance with the emergency order, I am confirming that we are providing public access to the meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom for this electronic meeting. All members of the committee and selective legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom and via phone by following the directions and links provided on the General Court website. We have provided public notice of the necessary information for assessing the meeting in the Senate calendar. We are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remote.senate@leg.state.nh.us or call 603-271-3043. In the event the public is unable to access the meeting will be adjourned and rescheduled. Please note that all votes taken during this meeting shall be done by roll call vote. Finally, let's start the meeting by taking a roll call attendance. When each meeting states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required under the Right to Know law. We'll call roll here based on those who signed up. Representative Nancy Murphy.
Here, home in Merrimack, not by myself, but alone in the room.
Amy Costello.
I am here in Dover and alone in the room.
Dr. Kathleen Bush.
Hi, everyone. I'm here alone in my office in Concord, New Hampshire.
Mindy Mesmer.
I'm here alone in Rye, New Hampshire.
And myself, Dan Tizik. I'm alone in Lee, New Hampshire. And let's get started. All right. So I sent out a draft agenda. I realized in retrospect that it was right before everybody left to go on to their Thanksgiving. So sorry about that. But the big item, do we have to approve last meeting's minutes? Is that part of this? Yeah.
It seemed like a good step. I don't know that we've been that formal before, right? But I think
you totally can.
Okay, I'm all about what we have to do. So a motion to approve last meeting's minutes.
So moved.
Do we second?
Second.
Perfect. All right. Next is the big ticket item, which is to discuss and delineate an updated list of health indicators, outcomes, conditions / codes as described in the 5th charge of the commission described in SB 85. So who would like to kick it off?
Well, I'm curious if anyone found any sources that they feel are really maybe a prime example. I feel like I've done quite a bit of searching today and can't find that original table actually. So if anyone in the group has put their fingers on that original table, that's super helpful.
I actually went looking for that about a week or two ago, and as well could not find it or an updated facsimile of it.
Right.
Yeah, in fact, all the databases that I found, it's not so much listed by indicator as in toxicant, and so we may have to sort of reverse work this by toxicant that we're interested in, and then what indicators it actually contributes to, and then work back, unless somebody else has found anything better. Because when I went looking, it was a little confusing to navigate around.
I like the idea of doing a backwards look. There's lots of papers, peer-reviewed papers that look at environmental triggers and outcomes that we could use.
On the NIEHS website, that's where I've been spending a lot of time sort of trying to find other pieces of information. They do list conditions and diseases, which is where I think that original document might have come from. And so right there's a list. I just realized I can't put a chat in there, but it's NIEHS. If you Google environmental health and conditions and diseases, so it lists asthma, autism, autoimmune, breast cancer, cancer, inflammation, kidney disease, lung disease, obesity, Parkinson's, reproductive health. I think that is very similar to the original list that we have. But then, right, you click on one of these and it opens up just a whole new website of information. And I couldn't find any kind of condensed list.
And is that the one, Katie, where there's also no PFAS is missing from the list?
Right.
Yeah, it's
and
not
so
even.
Then they have a separate list then of environmental agents, kind of to everybody's point here, and that's a much longer list of things. I wonder.
Is that under the health topics page?
Yeah, exactly.
Yeah.
So
Yeah,
environmental
I found
health
that.
topics, and then there's environmental agents. And so, we could prioritize this list. Again, I don't think it's realistic for this commission to try to wrap our heads around everything, but are there ones on here that we feel are a priority in New Hampshire? So air pollution, arsenic, scrolling through the list, endocrine disruptors, flame retardants, lead, mercury, PFAS, pesticides, right?
Radon.
So radon.
Radon.
Yeah, exactly. So this might be a way to have a pointed list, right, that we can refer back to, but say of this list, we've prioritized these exposures for New Hampshire, and then go through the added step of then these are the relevant outcomes.
Sure.
In each of those categories. I feel like when we're developing a framework, we want to be able to point to things, right? And so to Mindy's point, if we find a reference then that links an exposure and outcome, we can kind of plop it in to our framework and have that citation. But I feel like what do you start with? And so to be able to point to something with this is what we started with and narrow it down from there is important.
I think what you just said, Katie, in terms of, we know arsenic, radon, PFAS, those are, what lead, whatever the you guys are dealing with as priority issues at DHHS. And then we can link things to, I'm thinking of PFAS to the C8 study. There are all the health impacts that we know. I don't think we have to reinvent the wheel, but it would just, which way do we come at it? Do we go for the health impacts? But I think it makes probably more sense to look at the toxicants and then, come back to the health indicators and associated health indicators.
Just
There's no
emailing
way we
everyone
can
that
address
link
everything.
in case you can't find it. Just sent it all over email.
Looks it looks like they pulled that stuff down on purpose. It looks like they're trying to implement a new plan. So they have some of these things still there, but they're not in the same sort of table, and lots of errors on the links. So interesting.
I know. Yeah, I think it.
I mean, we still have that table, so we can just populate it ourselves, take things off we don't want, put things on we think we need. It's a good starting point anyway. Do you want to start it as like a Google Sheet or something and have everybody work on it, or?
Sure. I could set that up.
I do think too, we talked a little bit, we've touched on this topic of kind of what is our endpoint of interest, right? So, and what are endpoints that we know might be relevant? So thinking about PFAS, for example, and like impact on cholesterol. So we know that that relationship might exist. We don't have an endpoint really at our fingertips necessarily that lets us identify that as an outcome. And so in creating this kind of repository, I feel like it's important to maybe capture out, what are these called? Endpoints of interest. So, right, increased cholesterol could be an endpoint, but the outcome may be something else, or or again, we may then limit what we would suggest, say that the health department actually conduct surveillance on to outcomes versus an endpoint that we actually have data on.
So I'm sorry, Katie, are you saying though that so the outcome, let's say the indicator is hypercholesterolemia, that the outcome could be coronary artery disease or something like that.
Yeah, like whereas one is sort of a clinical marker, which might exist in someone's health record versus a billable code that will exist in our hospital discharge data.
Got it.
And so I guess are we trying to summarize the science, or are we trying to provide guidance to a surveillance program? So like we have to kind of bring that lens of feasibility. And Amy, I always really forget about what is available though, thinking about insurance claims. Still, we wouldn't know about an increased cholesterol level, even from insurance probably, but.
Only if you saw the condition code for hyperlipidemia.
Right.
Yeah, so you wouldn't see, like for diabetes, you wouldn't see like an elevated HbA1c result, but you might see a diagnosis code of diabetes.
Right. So.
And so whether that diabetes is attributed, and we had talked about this, I think, in the 511 committee, like whether the diabetes is attributed to PFAS or it's attributed to diet or, other things. There's sort of that attributable risk that goes with the outcome, which doesn't mean that you shouldn't track the outcome or the intermediary markers. But the interpretation of all of that, we have to be careful.
Yeah, but our goal isn't really to limit the ability to understand health impacts in New Hampshire. Our goal is to identify them and how we might get them, right? This doesn't like Ascension take, EMR databases and stuff like cholesterol and T3 and all that stuff. Don't they collect, isn't that information somewhat available in some of these databases that then could be repurposed and used for what we are looking at here? Because we'll never know if a diabetes is linked to PFAS exposure or diabetes is linked to dietary or whatever. But we'll know from a population standpoint if people who live in Merrimack have higher levels of cholesterol. So we don't really want to limit, you know, what we're looking at with factors and all that. We want to be able to get to the base data.
Yeah, I mean, your point's a good one. And I think that was the charge in the agenda, was just to identify the conditions that may be related to this.
But again, like, so for example, like if changes in liver enzyme is what the literature says, but all we can really track is, say, liver disease. Do we want to take that step of identifying liver disease as the outcome versus liver enzymes? You know?
You can track now, right? But what we're looking at is the future needs, not just what we can do now.
Well, I guess that, I mean, that's kind of is a question, I guess, of our purpose. Like, do we want to be able to put legislation forward right now that helps improve our operations right now? Or do we want to put some bigger, lofty ideas down
Both
that could improve? Okay, so like short-term, long-term.
I think we're identifying the gaps. That's a perfect example. You know, the cholesterol, the thyroid. Those are the, you know, we may have a cancer registry, but nobody's keeping track of, you know, of the thyroid piece of it.
Yeah.
So I think it's both. I mean, I think we all acknowledge that there are limitations in the system that we're working within, but that doesn't mean we shouldn't figure out what those limitations are. And, you know, we know it's going to be none of this is going to get solved quickly, but that will help drive the legislation we need and the funding for resources at DHHS and DES and every place else. So I think it's important to look at what we want, not what we currently can do. What you know, what those, and I think the thyroid and the liver enzymes are perfect examples of things that, you know, we know certainly bear looking into. We may not have that ability right at this moment, but that's the gap that we've identified. You know, how do we do that? How do we do that? You know, maybe not now, but what's the plan going forward so that we can do that, along with whatever else we can collect that, you know, that's easier with codes and stuff for right now. So I think it's, I think like Mindy said, it is both.
Okay, so if there's clinical marker, like if the literature supports a link between an agent and a clinical marker, that's, you know, that's one thing. If that same agent also has outcomes or diseases, with that, so I'm sort of envisioning like the matrix, you know, that shows like PFAS, the clinical markers, the ultimate outcomes, and then the sources of data for both of those. You know, so if clinical markers is de facto EMR, you know, electronic medical record, then that becomes a known gap, you know, and if there's a database that, you know, needs to be tapped for that, or if there's legislation to enable looking at EMR data, you know, that's one thing. You know, if the condition is something that can be found in the discharge data or the claims data, then that is something that could be done now. So almost like clinical marker, disease outcome, now or later.
Yeah, perfect. That's exactly what we should do.
It has to happen.
You know, because we did do all that. You were in the first iteration of this commission, right, Amy, where we had all those people come in.
Yeah.
You know, so that kind of gave us where all these may lay in the state, and now we should put them all in a matrix.
Yeah, and I almost feel like it's been long enough that there's probably literature that's come out to support new, you know, or it's worth looking at, you know, okay, PFAS has been shown to have these clinical markers, you know, and the evidence is much stronger now, or where it was maybe a weak link before, you know, and there might be just some rock solid stuff too, you know, and there are some really solid agent to condition kind of relationships that are well known. Again, you know, there's, you know, I don't want to lose sight of the attributable risk piece, because I think that is something to sort of keep in mind, that if that becomes an important way of translating how much disease do we need to see, like what trips the threshold if it's variation across the state, but the state is equally exposed to this contaminant, you're not going to see variation. So what we have to have kind of a threshold that says like, wow, okay, everyone in New Hampshire has elevated rates of lung cancer. What the hell is going on? Well, it's something we're all breathing, you know, as opposed to, you know, if we're just relying on hot spotting or geographic variation, that should be easy to detect if we're just trying to compare to our neighbors. But, you know, being able to understand when does the rate of disease become high enough that we'd be concerned that this is related to a contaminant.
Is it worth benchmarking with the national average?
Absolutely.
Yeah.
We have the highest rates of several cancers in the nation. So that should be our focus on pediatric, breast, esophageal, you know, bladder cancer, which we're also already kind of addressing some of those, but.
Yeah, so I don't know, is it, can we share screen on this?
Yes, you can.
Oh, thank you. Just wondering if I can whip up a spreadsheet and if we were to start working through that, or.
I think that'd be awesome, Amy, if you can. I was thinking the same thing, and I just logistically was like, how do I do that?
Yeah. I'll pull it down some of this.
At least then we could have a template and could send it around, and I don't know, we could even maybe identify, like I'll take, you know, arsenic and radon, and somebody could take PFAS and kind of work through.
Sure.
That might be a way to. I think something that's super interesting, I was just on an email thread here, trying to do some just disease reporting at small areas, and what we continue to run up against, and what's just interesting for this group to maybe think about, it's not just the outcomes at these small scales, but the risk factors. So for example, we have very poor data on smoking and tobacco use across the state, which we know is a huge risk factor for a bazillion disease outcomes. And so this whole idea of like attributable risk is, we probably even have better data on the environmental piece than we do on some of these other behavioral risk factors. And so like, in order to
why is that
those, I don't know. Yeah.
Why is that data after decades of knowledge that it, you know, why is that? This is like, this gets to, you know, what we're trying to do here. It's not, you know, we're not necessarily focused on tobacco products, but, you know, that's a really good example of, we're still not,
right.
You know, caught up to what we know is attributable risk. So,
yeah.
I mean, I think
and I don't know what the solution is. I mean, I think it speaks to like larger data quality projects. I mean, when we think about kind of the lack of information on race and ethnicity in our data, or occupation, all these things that we know are kind of underlying risk factors, and we don't have, I mean, talk about legislative potential, like some of this stuff
sounds like another commission in the works.
Mandated, you know, some of it is mandated to be reported, but other
yeah, I think that's part of the charge of this commission, is looking at gaps like this and trying to figure out why, you know, and how to make sure we don't have them anymore.
Yeah, right.
Aren't there national grants or anything to do things like tobacco behavioral use, whatchamacallit, surveys like that, where we're looking at tobacco use in New Hampshire and race? And I mean, I think the state in general has been lacking from a public health approach to deal with these kinds of issues. So.
Yeah, well, yeah, and it will be interesting to see whether any of the investment in public health infrastructure changes at the state and federal level going forward. You know, certainly the BRFS, the Behavioral Risk Factor Surveillance System, and the YRBS are good tools. Oversampling to get a better, you know, better look at the state comes at a cost, but not one that couldn't be supported maybe through legislation. You know, I think that there are some good data resources that we take for granted, and maybe forget on an annual basis, maybe even myself included. Oh, if we want to get that question on, we need to come up with the extra $6,000. But $6,000 to understand on a statewide level a significant public health issue could be good preliminary data for a smaller study or even some sub-state analysis. Is that fair, Katie?
It is. And I mean, we do on BRFS, you know, we had started asking, for example, if people are on well water. So we have a general idea across the state about, you know, well water dependence. We also obviously ask about smoking, but like your point, we only sample, you know, between 6,000 to 8,000 people. And so we can only really create reliable estimates at a county scale. And so that, you know, I think to do what we want to do and look at sort of real geographic variation, and that would be linked to environmental exposures, we would need many more data points to be able to then slice and dice the state up more finely.
So what's the data on wisdom then for tobacco? Isn't there a tobacco use on wisdom?
Yep. But I believe it's only presented at the county scale. And so we don't have town level, for example. So if we wanted to look at, you know, it's just really hard to look at something like town level arsenic and town level cancer when we can't control for town level smoking. You know, it's like you need the risk factor data at the same scale.
Why can't you don't have the data?
Not at a town, right?
Because it's that from a different source or something?
Well, there's just too few counts. So you can slice and dice the data so many, but if we were to then look at towns, you'd have like 2 survey points in your town, and it's not reliable.
You mean for trace?
BRFS is
for
like
BRFS, for the survey.
Oh,
it's like
really?
6,000 respondents.
Yeah.
That's
the kind of high. Yeah, which is not very different from other states, you know,
No, right, it's very standard.
You know, proportionately, that's about what it is, because it's used as kind of at a state level to compare to other states. We use it at a sub-state geographic level, and oversampling or, you know, increasing that to 12,000 might allow you to go down to a lower level. But I would hate to have Dover make decisions based on 15 survey respondents.
Right. And what we did see, CDC a few years back did do the 500 cities study, where they did some statistical modeling of all that data to kind of downscale it to a smaller area, but they only did it for the 500 largest cities across the country. Nashua and Manchester were included in that. So we do have some of that, what I would call downscaled data, which, you know, could explore as maybe a pilot of, but those aren't the same places that we are necessarily concerned about for some of these environmentally related outcomes.
So one thing that just occurred to me, Dan, and this might be a process thing, but I think that the last time that we met, we talked about revolving clerks, and I'm happy to drive the Excel spreadsheet, but I took notes last time, so I think I'm out. But I don't know if we need someone else that is also taking notes about some of the things that we're talking about. Because I was just thinking in this spreadsheet, I don't have a super way for me to capture like, oh, that'd be great to get that off the BRFS if we had some more oversampling, you know, those kinds of things. But that is a super legislative idea. Would want to get it captured in some notes if someone is willing to take notes.
Which begs the question, does anybody want to take notes?
So I had already started taking some notes. I don't know, maybe it could be a collective effort. I'm happy to kind of draft up, because I had already sort of started some notes. And then we could pass them around and people could add any points maybe.
Are these getting recorded, these events? So
the meetings, yeah.
Where do those recordings live so we can refer to them for review of notes, Alan?
They're on YouTube, and you just go to the Senate live stream channel, and all of them are available there.
Okay, thank you. So, Katie, I have a question for you then, or maybe you and Amy. So, what kind of funding would it take to do a sufficient sample size to assess tobacco use in New Hampshire.
At the town level,
Yes. And the price of that possibly.
Katie might.
I don't know off the top of my head.
Wondering sort of like what,
Yeah.
what magnitude we're talking about.
And then, not to make it more complex, Mindy, but you then might want to think about, do we want to split youth from adults? You know, this
I mean, I thought they already did that with, I know my sons get behavioral, surveys through the school.
Yep, but if you wanted to compare each town to itself, you'd probably want to use the same instrument. So I just, without creating kind of a snowball, like, you do it by town and then someone says, okay, well, what about just adults? And, do we think it's enough to do just by town? I do. I don't have an argument against it, but I thought, if we want to really think about how do we expand this and do it right from the outset.
That's where I was going. Like, how do we plan for it to do it correctly?
Yeah.
So where does all that data go? The high schools getting queried on that? Is that must be more than a couple hundred data points then? Or
Yes,
is it
but it's
targeted?
not every, and Katie, I'm like at the very edge of my knowledge on this, but not every school has to, there's a statewide YRBS, and then there's also still school-based YRBSs. And is that still managed at DOE?
It's jointly managed between the health department and DOE, Department of Ed.
And not every school participates?
Right. So
Okay.
again, you might not have representation for your whole town. And that data, I forget, I think we generally put it out by school district or something. That also historically was on Wisdom. But again,
Like,
the same issue as you can't get down to like the low, high geographic resolution there either.
Mm-hmm.
That depends on, but you're saying that depends on whether or not they respond, right? The respondent numbers. But is there a target? I wonder if there's, I don't know, just thinking about how many do you need?
Right.
And then what are we already doing, and how do you enhance that responsive, this respondent rate to make the goals for each town?
Yeah.
And so that's funded by DOE and
I think largely from CDC federally funds both BRFS and YRBs.
Okay.
I don't know if there are any. I don't know about general funds that support either of those, but.
Yeah, I think there is something interesting about BRFSS where some grants can add questions. It's a very complicated process, I think, because you can only have so many questions on a survey, right? Because you can't make it thousands of questions. And so, but then individual programs, didn't at one point, like Katie, like the asthma program had added a couple of state added questions to the BRFSS.
So there are national modules that you kind of opt into, right? So you opt into the diet module, you opt into the opioid use module, you opt into the tobacco use module. These are all standard question sets that are used nationally. And there's a state added question section that you can add to, right? And I mean, I think they continuously are just trying to figure out how to fund this because it is kind of chronically underfunded.
Right.
To just meet the requirement, let alone, exceed the requirement to be able to downscale the data. So, but I can ask
it'd be interesting to take a look at that in detail, say what modules are available, what is the cost? Because if somebody's already set it up, it's a lot easier to implement than it is to start from scratch. But are there things that we can get some additional funding for if we think they're important, like lead, paint stuff? I mean, that stuff is really important too. Lead water or, particulates for asthma, all that, it'd be great to see what the cost benefit analysis of doing that kind of work would be.
Right. So I think we went down this road because we were sort of talking about the attributable risk and that's just a hard piece in all of this work. But I think that's again where here, at least, we tend to look to the literature to sort of define what the attributable fraction might be out there, and you know, where we have sort of meta analysis or like cumulative research to tell us. And then, you know, so there might be a statistic out there that says 30% of asthma is exacerbated by environmental triggers, right? And so that's kind of the statistic we use. Then you have, that's not the real statistic. I just made that up, but.
Right. And then you should look at the cost benefit for that.
Yeah, so. Do we want to, so I see that Amy is kind of pulled up.
Yes, I am ready when you are.
This will have to have several lines for each of the chemicals.
Yep. This is just a start.
So are we going to just pass this around, or are we going to do this real time, or?
What do you guys think is best?
I think for me anyways, it'd be best to put this on like a Google sheet and let us populate it, because it's going to take a little while to fully populate it. So that was my thought.
Could we, do you think we could work on like using the NIEHS list as a starting point, at least fill out the contaminants we think we're interested in here? So like I might add air pollution, arsenic, endocrine disruptors. I don't know. I'm looking through here. Like, do we have lead, mercury?
Pesticides, PCBs.
Pesticides, yeah.
I'm removing the lines just to make some. Pesticides / PCBs.
Or it could be its own.
They're separate.
Yeah.
Okay.
What about mercury?
Are there individual pesticides?
You could, that's why I need a separate line, because there's different PFAS and mercury definitely.
But maybe as we go fill it in, you know, if the literature speaks to like one specific element, we can kind of build that out.
And so if we were to just take PFAS as an example, are there several clinical markers, Mindy or Nancy, that you know, like off the top of your head, like
T3, cholesterol.
Oh.
Where's the document? I lose it.
T3. Thyroid.
Sorry. You said P3.
T as in Tom.
Oh, T3. And this is high cholesterol, right?
Yeah. Preeclampsia.
So preeclampsia is the outcome?
Yeah.
I don't know if I spelled that correctly.
And outcomes would be kidney cancer and
this is, so the T3 might result in
thyroid disruption.
Oh, what is
called thyroid disease, maybe? Yeah.
this? Yeah. So, and this is kind of the direct, like, what are we looking for? Is it hypothyroidism, hyperthyroidism, or both? Or like, how does that get?
Yeah, that's why I said we kind of need to do this. It'll take a little while.
Maybe add a column, Amy, that's like citation, so people can link to a reference. I just really think that's important to keep track of. And it, like the science is like evolving so fast too. So
Yeah. I'm gonna do that.
I mean, there's lots of like, you know, reproductive outcomes,
Low birth weight.
low birth weight.
That's, I mean, you know, that was just shown to be causative.
So
And this might be surveillance data. So this we might look at HDD and ABCD. So we have a code for that. High cholesterol, if that results in cardiovascular disease or CVD, we have a code for that. So,
Then you
Yeah, same with like kidney
Yes,
or
so-
testicular cancer, right? Kidney cancer.
PSA, yeah, for prostate.
Is it prostate cancer?
Yeah, PSA levels.
The markers would be PSA.
This is a good example, I think, and then maybe we can
Yeah.
kind of divide.
And so this might be EMR for T3. This could be EMR or HD.
So there's a different source for a clinical marker and a different source for, we kind of need like a clinical source, and then we need a, I don't know what you want to call it, like a prostate cancer as a registry source.
Yeah, I was thinking that too. Like this, so the hospital discharge data would have an APCD and registry with prostate cancer. Registry doesn't get low birth weight, but low birth weight's in the hospital discharge data, APCD and birth certificate.
What's APCD?
All payer claims data.
Oh, okay.
That's the paid claims.
Yeah.
Another for we also have death data, right? So we talk about vital records as being both birth data and death data. And so obviously we know people who have died from these different outcomes. So cancers, for example, the registry is a great source for understanding sort of current cases. And then obviously death data would show us the relevant mortality rates.
Mm-hmm. Should we capture that here, Katie, somehow? Like we can get death data on, we should be able to get them on any disease outcome condition.
Yeah, I mean, I don't think it's different than the other surveillance data sources you listed there.
Okay, but where we wouldn't get birth, yeah, so here.
So not for that one.
Right,
But
and
for,
until we're able to name a condition that's linked to T3.
FT3,
Right.
Sorry. Heart disease, right? Fatty acid disease, fatty liver, what do you call it? I don't know. Well, that's why I want to fill this in carefully,
Okay,
that particular one.
yeah, and it may be that there's like a few lines here, and T3, high cholesterol is the marker for CVD and then other conditions too. And maybe they shouldn't have separate lines necessarily because the surveillance data source is all going to be the same, but I would think like, well,
You know what we should do is for surveillance data sources, we should have subcategories and sort of almost like check boxes for each of them.
yeah, I think that's a good idea.
Then you would be able to capture all different sources.
Yeah. I can fix that after. So you're saying like HDD?
Yeah,
Don't
and,
call it
like
ABCD.
have
Yeah.
surveillance data as the umbrella,
Yeah.
and then all the different sources. That way,
Yeah.
if we find a new source too, it's easier to add.
Yeah, for sure. I'll make a note to do that. And then short term. Oh, what do I mean by this? Like short term.
like goal or target, right? So versus.
Yeah. Yeah. And so I think this was sort of around the notion, Nancy, like what you were talking about before, what we were all talking about before, where like, if we need to be able to access EMR data, or we need to oversample the BRFS, or something like that. Like maybe that would be the short-term goal. So maybe not all of these have short-term goals, because so many of these are gonna
Yeah, this is more of a check. This is more of a checkbox. Is it a short term or is it a long term goal, right? More like if something exists, like say the low birth weight, birth registry.
Oh, like can we do it? Okay.
Yeah. Quickly.
Okay.
This should be a target for us.
Okay. But maybe we'll put notes over here, like if there's some general note about PFAS, like look for module on BRFS.
Yeah.
Hmm.
Citations you might want to move to right before notes too, just because it could potentially.
I put them for clinical markers and for conditions.
Oh, okay. Yeah.
If that's okay, because I think they're probably going to be, they may be the same, but they may be different.
Mm.
As you get into it too, Mindy, if you're going to take the first crack at it, I think you're going to see how the spreadsheet might work better.
Yeah.
Oops, that's not fair to anybody. Including myself. Can't see my name. Can't see my- Well, I wish I had my easy button.
You might want to add like benzene and MTBE to this also.
And the other contaminant I was looking at, acrylamide, really common in fried foods. Not that we eat that in New Hampshire, but maybe worth looking at.
Can you spell that for me, Dan?
Yeah, it's ACRYLAMIDE.
Doing this for me. Okay.
On the PFAS, can we add the elevated liver enzymes, or is that? Because I know that was it wasn't necessarily liver disease, but it was the labs were indicating the elevation in the enzymes.
That would be in EMR records too, right?
Yeah. I think, right? I'll do this.
And you could put like tick-borne disease on there too. In a way, would that be something? Maybe.
Hmm.
I'm going to ask Dr. Bush. Do you consider, is tick-borne disease managed in environmental health?
Yeah, it sort of crosses boundaries. I mean, it's certainly considered an infectious disease because there's a infectious agent. But obviously, your environment,
Climate change.
quite impactful. So.
No, that's a great point. I had just been focusing on toxicants per se. That's a great point.
Yeah,
then that begs the question, mosquito-borne illnesses?
Do we want to
Yeah, or do we want to
like
keep it? I mean, for now, do we want to keep it focused here and try to build this out and, have a parking lot, of like other ones to sort of keep our consideration?
Yeah, or a phase 2. This looks huge.
Right,
Yes.
right. By the
This
time we
looks
build that out.
enormous. But I think it's great to have, I like the idea of a parking lot or a placeholder.
Yeah. Future.
Yeah.
I mean, because it is an indicator, those are both indicators of climate change. So that's an environmental factor, right? But not as direct as what we're doing. What about the
Well, that's-
cyanobacteria stuff?
It's listed on the NIEHS website, and I think we do see that
Yeah, we do.
becoming more of a concern in New
Here,
Hampshire. So
A huge
Would it
issue
be
at the lakes, I know. This summer's
here,
been
or
a,
would you put it here?
I would keep it. I would put it in the original list. You know, it's off the same base NIEHS list, and it is a it's a chemical, essentially. A biological chemical, but a chemical.
Hmm.
Um,
Other things on the NIHS?
you know, one, not on that list, but I'm just looking back at the trace water results that we got in our community. And one of the huge issues for us here, we've been talking about it for a couple of years, is the sodium level in our water. And I, from what I understood, some things can't be changed because of things being grandfathered and parking lot salt in the winter. And, you know, we're looking at elevated, what do you call it? Oh my God, elevated blood pressure and things here in our community compounded by the other things. I know, you know, I'm just looking at my water report and this is a public water issue. It's a big public water issue here. So, you know, for me, that's a big concern is the sodium. The other thing that I don't know, we have the VOCs, right? And they're,
No.
we don't know.
we don't. Okay, VOCs. Yeah, bromoform, bromodichloromethane in our water here.
Those are
Public
water
water.
treatment byproducts.
Yeah,
What kind of byproducts, Mindy? What did you say? Sorry.
Water treatment,
Oh, interesting.
tetrachloroethane.
that's not a byproduct.
Yeah. Health goal is 0, results 1.80.
And so how do you want me to capture this? I'm hoping
I
you're,
think for now, keeping
Just leave it
VOCs as a
VOCs.
category,
Yeah.
and then
Okay.
if we find
That's a good idea.
specific linkage, we can add
Yeah.
out the line. Because I think again, right, and we'll have to do that for PFAS. I think, right, you know, not all PFAS, not every single PFAS compound will have this. So try to build out the table in such a way that calls that, you know, we have a family of compounds and then, you know, specific analyzing within a family
yeah,
where we have the linkage.
Flame retardant.
Yep.
what's that?
Flame retardant.
And we may find, you know, endocrine disruptors, for example, is a family of
Yes,
chemicals, and many others, you know,
right.
we reorder the list, I guess.
And
Yeah.
those include, it crosses over with
Yeah.
PFAS.
So maybe that's not the right category. You know, it's not really a chemical family if we're trying to keep this to chemical families.
Is PCBs, PABs worth?
We have
putting in?
PCBs. Is PABs the same? Is it /PABs or are they separate?
What's
I don't know.
PABs? What are PABs?
I can't remember what it stands for, to be honest with you.
Do you mean PAHs? Polyaromatic hydrocarbons?
Maybe. Yes. Sorry.
So that's another family,
Mm-hmm.
not the family you want to spend the holidays with. Yeah, and I think, you know, what I'm really interested in looking at is like, okay, so then how much are we seeing of this in the data? And you know, where hospital discharge will show you who came in the hospital with these conditions. The claims data will show you of those that are insured, which is a lot, it's 95% in New Hampshire, who walked into their primary care physician with these issues. And for cancer, you know, the registry is probably the best source, but for something like CVD or preeclampsia,
ulcerative colitis.
those are going to be really interesting to see in the claim data. Where would you put ulcerative colitis?
So it would be another, you'd have to like copy line 5 and insert it and then add it as a clinical outcome.
We just nail down the codes for those. But I can ask a student to look for those.
And then what about the outcomes that we know are problematic but don't know what they're from? So I wonder if there's a way to
Like reverse engineering it?
Yeah, pediatric cancer, you know, pancreatic cancer, breast cancer.
But we don't know the contaminant that's related.
Yeah, we don't know a definitive tie yet. Should that be like a list with a blank in the contaminant?
How do they know it's environment? Like, so the literature is saying that there's something from the environment, but they haven't established a link to a particular.
Some we do, like bladder cancer, we know is somewhat related to arsenic.
Right.
That would be under there. But like breast cancer, people think there are environmental, I mean, and it's not, you know, it could not, you know, maybe it's not 100% attributable to some environmental exposure, or we'll never know what that is.
Right.
You know what I
mean? Aren't these all like low birth weight?
Yeah.
Is going to be like smoking or drug? Like, what is it?
Right. And, but since we know, what's that?
I think it could still go in here. I mean, maybe there's a way to record sort of the strength of the evidence, you know, so you could have like a scale of 1 to 5, and you could say like, you know, breast cancer is the condition. I'll drop it in here.
Right, with no known, yeah, that's what I was talking about.
And then
have that be blank, or
what would it maybe be?
Well, there is some suggestion of PFAS exposure, but you know, the strength of that connection is probably right now not really strong. There could be probably other things, but
yeah, let's obviously you will get the first crack at editing this, but I'm wondering if we put it here so we don't lose it, and then we put something up here that allows for, you know, it's not a, what is it, Cochrane's evidence, but you might be able to, we might be able to then categorize these kind of priorities for exploration by saying, okay, look, that is a 1, you know, and this has like a 5 or something. Then we go after all the 5s and those conditions first. If we have to do that, if we have to prioritize them.
Well, what about also if you reverse engineer and say, we have really high rates of breast cancer in New Hampshire, so that should be a priority to determine possible ways to reduce that, even though it's not 100% on one cause. It could be 5 different causes that we could use for prevention. You know what I mean? So there might be a way to public health priority or something like that.
Yeah.
You know?
Yeah.
Like bladder cancer is really high. So we've done some stuff on arsenic, which is great. There are other factors though too, right? Which we know about smoking, right? Or
Mhm.
Should we have kidney cancer under disease outcomes for
Yeah,
PFAS?
we have to add a few of them there.
Yeah.
And is this meeting an hour or an hour and a half?
I was going to say, I thought an hour.
Yeah,
I
that's
thought
what I had committed to.
More time if you'd like it. We will not be booting you guys off.
Well, the person that has the control of the spreadsheet is the least useful for populating the spreadsheet. So I'm happy to pass that on to Mindy.
Okay.
And then that might be the best use of time. So I'll stop share. What are best next steps? Stan, let you send this off.
Yeah, I would think splitting up the listed toxicants and start some filling in the blanks. And given the list that we have, I think that's going to be fairly sizable.
Mm-hmm.
Any other thoughts?
Split it up or put it on a Google Sheet thing.
Yeah.
Oh yeah.
I have a hard time accessing Google Docs from inside the state. So if we
You
could, yeah, I can't get to them. So if we could also just use a static and then maybe somebody can copy paste my contributions.
Do you have a hard time, Amy, also?
It's okay. It's not the software.
Is there a better one that we can do like that where you can do a working document? No.
Teams.
What's that?
Yeah, Teams.
Teams?
Do you have Microsoft Teams?
I don't know how to do it, but I can figure it out. Does that work for you at all, Katie?
It might. We have access to that. I have not used that function. I'm not sure. So
It's pretty cool.
I may be just stuck with a static version, but
I'll tell you what. Let me try to work that because I actually have a Teams account through my work, my civilian work, and then my military. So why not 3 of them? And so I'll be teaming all over the place.
I just think it's easier to track. So if it's hard to track when you make changes to a static document, that then gets,
yeah,
harder.
Yeah.
So Dan, I'll send this to your Yahoo account as well.
Perfect. Thank you.
Okay. Thank you for setting
I just want to say thank you guys from the citizen point of view. This is what people in the communities have been asking for a long time, to feel like somebody's saying, hey, these are the things that we're seeing, and start looking at what do we need to do. And so thank you. I really, I know that will mean a lot to community members when we can say, we're looking at the things that we're seeing as priority environmental issues in the state and trying to figure out where we need to go. So that's one of those things that community feedback, that it will be is important for community members to know. And I emailed, and I think it was Katie, to your email, just the little blurb that I talked about to put, in terms of community feedback loop. I don't know if that's exactly what we're looking, just a few lines, but certainly feel free to cut, paste, edit, but just sort of to recognize. And I think this is a perfect example of that, the responsiveness to the community, not just telling them and informing them and educating them about an issue, but responding to it. And I think this is a great example of that. So thank you.
Thank you.
Yeah, thanks for that. And a good segue here to, I do have this report still that we looked at last time, and I was in there again today, just cleaning it up. So maybe I can do my best to type up notes from today and send an updated version of this report. And then we could send both of those to Senator Sherman. And I think maybe this is something you could do, Dan, like once you have those, I'll just send them to this group and we can kind of weigh in and make any additions. And then when they're kind of final, like Amy did, send them off to Senator Sherman. But I think we could also include, is it Aaron? Alan's helping us now. Aaron helps behind the scenes, right? And he can post a lot of this stuff to the website. So I didn't follow up with Aaron last time to make sure the documents kind of get shared more broadly.
Okay.
And just by way of I think it was the third agenda item, the plans for meetings. I have not heard back from Senator Sherman about when would be best to pull somebody in. So Dan, if you want to nudge him a little bit when you send the other pieces, I'm happy to help try to facilitate that. I want to be respectful of what else he's hearing and what else he needs to get onto the agenda.
I can do that.
And I think mine was specifically around the EBI, getting someone in to talk about the EBI from DHHS.
Yeah, I did also talk with folks on that note, and that can be a section in this little report, I think, or in notes to Senator Sherman too, around suggestions for future presentations. I did talk to the maternal child health folks, and they're eager to have a conversation about the birth defects registry. I think right now everyone's working on a grant renewal. So they said they'd be happy to circle back once they catch their breath, but would be happy to either give me an update, which I can then provide, or maybe even come to a future meeting and give a presentation on that registry, which is something I think, we're all familiar with the cancer registry, but this could be another one. So,
and Katie, is the grant renewal actually going to include like a description of their future plans? Like, does the activity of the grant?
I don't know that it's specific to the birth defects registry. I think this is like other just birth outcome work that they do within the section. Yeah. Same staff though, so they're just
taxed. I didn't know if there was going to be a section you could just lift from that would just help eliminate.
Yeah, I don't know. I guess we'll see. So once they finish putting it down on paper, they could share with us maybe. It's always good to hear from programs. I think about kind of what their core work is and how these environmental pieces fit into their core work. So,
good.
So,
when would you like to meet again?
I wonder if we should wait till the full meeting happens. That's coming up, right? And sort of see what the vibe is coming out of that meeting, and then.
Sure. That sounds good. Remind me again, when is the full meeting?
Yeah, I was just checking.
I had it here.
It's December 8th. It's next Tuesday.
Yeah, so that's my thought. I mean, and we can just at that meeting decide to schedule again, but like, let's come back together maybe as a group and make sure I don't think we'd meet before then anyways, so.
Sounds good.
But do we want to plan to share this list at the group, or share at least the plan? Well, I guess in our communication with Senator Sherman, we can kind of give him some options of, I really liked in your update, Amy, how you said like, here's what we could be added to the agenda, or some suggestions for presentations. So we could maybe follow up with a similar email after today's meeting.
Yeah. And I'm comfortable with sharing drafts in this format too. If Mindy, you get a chance to look at, or whoever gets to add to whatever's shaping up, but then for people to have a sense of what we're working on. And if there's other members that have clinical background that can add to this, we're dubbed the data subcommittee, but this is a really, pretty significant clinical juncture that I don't have. So, others that could contribute, that would be great.
So are you saying share this at the next full meeting?
I think so. Kind of an iterative product, of like, here's the template that we're working with, and a really, dirty pass at the PFAS information, and whatever others have had time to add before the 8th.
I think we're going to be, Nancy, correct me if I'm wrong, but I think there are going to be new legislative members on the 8th. So we're going to lose a Democratic appointment, state rep appointment. Right. I think we are. And gain a Republican.
My House position will be replaced by a Republican member, and I don't know if they'll have it done by then. But I just actually got confirmation that Senator Susie has just reappointed me as to this commission, so I get to stay. But my House position will be need to be filled. So there will be a new person, but that doesn't necessarily mean it's going to be, depending upon who the appointment is, will determine whether they're, this has been an interest or somebody that's been involved sort of in the periphery. I don't know.
Yeah.
So at least one, right? Is it just me?
I think in this commission, it's just you, but then there may be, I don't think there's a Senate change, or maybe there is. I can't remember.
There were, oh, no, because I don't think so. I think all the senators were Republican senators, so that shouldn't change. Yeah, but if he's not, he's already appointed to it. So I think unless he leaves, unless he resigns, he stays.
Yeah, correct.
So they shouldn't. I don't think there's anybody else to my knowledge. I think
can't
it's
remember.
Jeb Bradley and I don't know if it was somebody else. So it may just be one additional new person. Maybe Alan would know. I don't know. But I don't know that will happen by the 8th.
Right.
But I think it's a very good idea, Amy, just to, I know, because we're with the education subcommittee too, just to bring, give them a sense of what's going on, what we're doing, and, and then anybody that wants to reach out and add stuff or,
And I think it's good. I think it's good in a way that table is no longer available in some ways, because this will become much more of a New Hampshire specific,
Right.
effort.
And the framework is from NIEHS, but the things that are really New Hampshire related. We have spots for all the scientific citations. And this could become a really great landmark document.
Yeah,
I agree.
I think it'll be a paper submission. I'm kind of curious, actually.
Well, I mean, it's such a great tool because it will be not only useful for this, but it will be useful for like the 737 Commission and others. So, in other programs too within DHHS. So it's a great tool that will be, I think well utilized across the board. So I think it's a wise investment of time and effort. And as Amy said, it's specific to us. And we got our work cut out for us, but it's worthy work, and it's something that we really need to look at. So thank you for letting me be part of it.
When does the subcommittee meet again? When does our subcommittee meet?
This one, we just said we were going to wait.
Okay, just wait and get the vibe next Tuesday. Okay, all right.
Unless people prefer to set it, we could. I just feel like it's good to check in.
I think I'm okay with that. If we keep, harassing each other through email to move the document forward, I think that's probably that's an opinion, but I think if I used my hour to really dig around and get the research, focus in on one contaminant and associated conditions, and I think that could be.
Yeah, I think it's going to be a team effort too, because while I might be able to put in stuff about, recognized clinical outcomes or whatever, you, Amy in particular, will know where those data sources can be derived from. So those check marks in those columns, so it's going to be a joint effort.
Yeah. And we've got students to help with pulling the codes and things if we want to put those in next to the conditions so that we can move.
Oh, that's a good idea. Can we do that? Yeah. Yeah. That's a really good idea.
Absolutely.
So just when you get in there, Mindy, feel free, like if you send it back around, then I think we could divide and conquer. I'm happy to take a handful of the contaminants and just dig in. It may be a way to make more progress, but
Same here.
Or if you want to do a first pass or something.
But Dan, you're going to put it up in Microsoft groups or something?
Teams. I'm going to try to set that up.
Yeah. So that's probably going to be the best way to no dividing, then just go in and conquer.
Okay, awesome. Yeah, I like it. That's great.
All right. Well, motion to adjourn?
Second. Oh,
And I have to call roll, don't I?
Yes.
You do.
Oh, okay. So Representative Nancy Murphy,
yes.
Amy Costello,
Yes.
Dr. Kathleen Bush,
Yes.
Mindy Mesmer,
Yes.
and myself, Dan Tizik, yes. And meeting's adjourned.
Great.
So
Thanks,
take-
everyone.
Thanks,
Thanks.
everybody.